Yeah, so I think going forward, one of the things that we have already been seeing is that quadruplets will likely become the standard of care for induction regimen, especially in transplant eligible patients, and in my opinion, even in select transplant ineligible patients who are otherwise able to tolerate those treatments. The reason being that over and over we have seen that in multiple myeloma, using the best treatments, first, it usually leads to a very long first remission and subsequently translates to an improved progression-free survival and overall survival. So I think the using all the effective therapies upfront, along with high dose melphalan and autologous transplant, and that may be debatable down the line once we start using all these drugs, whether we really need to do transplant in everybody, or can we stratify patients based on the MRD status after induction therapy. But quadruplets are likely to become standard of care for frontline myeloma. In my practice right now, VRD is still the regimen that I am using for most patients for frontline. However, I have to say that in high risk patients, based on data from the Griffin trial showing a high MRD negativity rate overall, and data from the Cassiopeia trial showing the high MRD negativity rate even in high-risk patients, post-consolidation stage. I am using quadruplet, either DARA VRD or DARA KRD in high-risk patients for induction regimen, obviously in selected patients who I think will be able to tolerate a quadruplet regimen. Yeah, so one of the challenges which I think we are all concerned about is that if we use all the drugs up front, when the patients relapse, what are we going to use, right? So if they're relapsing on a anti-CD38 monoclonal antibody and on an IMiD and plus minus, maybe even on proteasome inhibitor, then we are kind of burning out all our options. And what are we going to use at relapse? I will say a couple of things which, in my opinion, kind of allay some of those concerns. So one is that, we have two very exciting drug classes. The one is the BCMA targeted therapies, and we can talk about either ADCs or BiTEs or CAR-Ts, and the second is CELMoDs. These are all very effective treatments that are coming in the pipeline. Some of the BCMA directed therapies are already available, and those will likely come to the first relapse space in the future. So that will likely be able to take on patients who are refractory to, let's say, anti-CD38 monoclonal antibody and maybe PI or IMiD combination. And the second thing is, I think as we are, as several MRD adapted trials are currently ongoing, and it's not necessary that all patients will stay on all treatment, indefinitely in first remission. Patients who achieve MRD negativity at certain time points may be able to come off of treatment, and hence they are exposed to those treatments but not refractory, and we can potentially reuse them, subsequently if the patients relapse. So there are, it's still a lot to learn, and we'll see how, the field evolves in the next few years. But I will say that, these are some of the concerns, and obviously cost, especially if we are going to use a 4-drug regimen indefinitely, that's going to add a lot of cost. However, if we are able to achieve, early and sustained MRD negativity and get patients off of treatment, that will lead to cost saving as well. So, many trials, going to be read in the next few years, and that will, hopefully, like, enlighten us with more knowledge regarding how to best use these agents.